So you check the growth hormone value before going for a GTT test, and you do the growth, give a 75 gram glucose, and again you check for the growth hormone value. It should come down below 1 nanogram. If it is not coming down, you are dealing with a case of acromegaly. So you go for a MRI brain and you tell you. You can also go for the insulin-like growth factor, which doesn't alter with the blood glucose value. That was another case which was discussed. Somebody comes with a madarosis, what you will look for. Any patient comes with madarosis, hypothyroidism can be a one thing, where they have a loss of hair. Leprosy patients will have a loss of hair. Or sometimes autoimmune disease like the SLA, all the other things you can look for. Hirsutism is a very common problem you come across. In a female, hirsutism means they have a hair growth. But be careful, somebody comes with a hirsutism sudden onset at the age of 40 or 45, sudden onset. Within 1 week, 1 month, 2 months, they say, you think of a malignancy. Because the testosterone can come from only two places, either from the ovary or from the arteries. So if anywhere is it, usually hirsutism means PCOD. But if somebody comes with a sudden onset, it may be malignant. You test for the testosterone value. If it is very much elevated, you are dealing with a case of ovarian malignancy. Or you go for a CT abdomen, we can find out, differentiate between the ovarian tumors or a adrenal tumors. So, somebody comes with the smell, the halitosis, that also you can diagnose because some things, fruity odor, you know, the diagnosis is there. Diabetic ketoacidosis. Somebody with a fishy odor, maybe you are dealing with renal cases. Somebody with a fetal hepatitis, maybe an intestinal obstruction. Most of the time, nothing but this is a gingivitis which is producing the halitosis. Another thing which we discussed was Horner syndrome, that is ptosis, meiosis, and hydrosis. Somebody comes in the casualty with the Horner's after an RTA. You think the patient is having a spinal cord injury because it comes down up to T2. You found a patient comes in the casualty with the Horner's, look for a spinal cord injury. This comes like this thing from the hypothalamus. There's a 3 order neurons are there. From the hypothalamus comes down up to the T2. That is the first order neuron. From the T2, it goes to the superior. You can see that this is the superior cervical ganglion. Then comes from the area here to here. This part is a bifurcation of the carotid, where the apex of the lung is coming. So somebody is having a Horner's, somebody is having a radiculopathy, is some call for something. You look for the Horner's is due to the Pangos tumor. That's the one thing. From here, you know, this diverting and goes to along with the internal carotid artery. That's common carotid artery. That's the third part is going along with the internal carotid artery, goes to the carotid canal and to the cavernous sinus. From there, the superior orbital fissure. Okay. If somebody is having an accident, undergone a carotid stenting, something is happened. If the patient is developing a Horner's, maybe have injured the carotid, that's one thing. If somebody is having a severe headache on one side with the Horner's, some amount of the TAA or something is coming, you are dealing with a case that the patient is having a dissection, getting a dissection on the internal carotid artery. If this is the area from the hypothalamus down, the first part is there. One, say, a big baby, a diabetic mother born a big baby, just taking out the baby, and you find that the patient is having a Horner's, the patient may have injured the Erb's palsy, may be the reason. But commonly in the clinical practice, one of the things is the area from the hypothalamus down to the T2, patient is having vertigo, having giddiness, patient is having ataxia. Any of this thing is there's a brainstem sign is there. Okay. When it comes down, the patient is having a crossed hemisensory loss. There's a phase, there's an impairment of the temperature, pain and temperature on one side of the face, the opposite, the contralateral hemisensory impairment. trigeminal involvement. The patient has a lower cranial nerve involvement, like 9, 10, 11 cranial nerve involvement. The trigeminal nerve on the same side, the hemisensory pain and temperature on the opposite side. You may be dealing with a case of the Wallenberg, where it could be a vertebral artery lesion or a posterior inferior cerebral artery. Any of the things that can be diagnosed with that Horner's alone. So, if somebody sees Horner's, it's very, very important in the general clinical practice. Okay. This all we have discussed about in the last class about the morphin, the myasthenia gravis, and hyperthyroidism. Just acetylcholine receptor antibodies and atropine challenge tests all were discussed in the last class. Okay. So, coming to the spleen, as Sir mentioned, it is a challenging task for many of the treating clinicians, the splenomegaly, because as I mentioned, there are 101 causes for the splenomegaly. They comes in a various combination. It comes with an arthritis, with the lymph node, with anemia. So many combinations comes. So the clinician's role is narrow down the lesion and arrive at a reasonable diagnosis. So many combinations you come across. So I'll be discussing the splenomegaly in the following heading. This is something about the anatomy, etiology, and stepwise approach. Spleen is a structure, it is located in the left hypochondria between the 9 to 11 ribs. This is mostly on the posterior aspect. So the measurement is like an odd number, 1, 3, 5. It is a 1 inch thick, 3 inch width, 5 inch long. It is a 7 pound weight is there. And it is located between the 9 to 11 ribs. And the radiologist always say, it is anything more than 13 centimeter, it is splenomegaly. So spleen got a white pulp is there, that is concerned with the immunological, and the red pulp is there, which is concerned with the filtration. There are certain structures very closely associated with these things. The stomach is there, the tail of the pancreas is there, the splenic flexure of the colon is there. So all these structures can mimic an enlarged or a mass in the left hypochondria. Any of these structures can produce that. Coming to the arterial supply of the spleen, the aorta, it comes from the diaphragm wall, the 3 openings, the one for the esophagus, one for the vena cava, and at T12, it is the opening for the aorta. Then immediately it comes down, aorta gives the first branch, that is the celiac trunk, that is the artery of the foregut, which supplies up to the second part of the duodenum. And the next branch is the L1, which supplies the second part of the transverse colon, and the rest is the L3, that's the inferior mesenteric artery. We are concerned with the celiac trunk. Celiac trunk got 3 branches there. One is the left gastric, the splenic, and the common hepatic. The left splenic artery goes along with the head of the pancreas, the superior surface of the pancreas, to reaches the hilum, where it ramifies the upper and lower branches there. But spleen also supplied by a small branch from the left gastric and another branch from the gastroepiploid. So this is important because when you go for the splenic resection, you may have to ligate all the 3 vessels. The venous supply is from it's got the splenic vein is there. That's a portal system. The blood supply to the spleen is about 150 ml per minute. It is a low flowing structure. Maybe it is for the filtration purpose is there. Okay, low flowing structure is there. So the splenic vein and superior mesenteric vein joined form the portal vein, which goes to the liver and this ramify over there. Spleen also got certain ligaments are there. One of the important ligament is it is suspended over there from the stomach. That is a gastrorenal ligament, and from the inferior leg, it is from the renal ligament. There are small branches of the artery going along with that. Then got two surfaces there. One is a diaphragmatic surface which comes very close to the diaphragm, and the visceral surface is there. Visceral surface has got all the peritoneal attachment except at the level of the hilum. On the visceral surface, there are certain impressions are there. One is for the gastric impression is there, the renal impression is there, the colonic impression is there. It's all because of the pressing of the different